Today's topic is musculoskeletal disorders. So we're going to talk a fair bit about fractures and different kinds of fractures, some other bone diseases, and then we'll touch just a little bit on some of the muscle diseases. This is another one where I've shortened. I took out like some of the muscular dystrophy stuff and some of those things that I don't think have, while they're clinically relevant, you don't see those patients very often, and typically they're being treated by specialists anyway. So instead, I uploaded the new shortened version to Angel, so if you want to get a copy of this, you can do that. All right, so like we've done for the last few chapters, many musculoskeletal disorders, we use the same kinds of tests regardless of what we think the disorder is. So for bones, radiography is obviously a mainstay. Your classic x-rays are great at telling us things about bones. They're not great at telling us things about lots of other things, but bones, radiographs are very, very good at. There's also a thing called a bone scan, and this is where the density of a bone or bones can be determined. So like in part of the preventative care for osteoporosis, we have people do what's called a DEXA scan, which is a bone scan that assesses bone density for calcium and osteoporosis. For muscular disorders, there's a fancy test called an EMG, an electromyography. This is where some electrodes are actually inserted into the muscle, and the electrical activity is followed. It's a way to determine if a problem with the muscle is a nerve problem or a muscle problem. If the EMG is normal, but that muscle isn't behaving properly, then probably it's a nerve problem and not a muscle problem. So it's a way of discriminating those two things. Let's see. Write you down. Okay. For joints, x-rays again. Arthroscopy is where we take a small little camera and we actually look around inside a joint to see the extent of like osteoarthritis or rheumatoid arthritis. MRIs are useful for joints, muscles, and bones. MRIs give us a three-dimensional picture that we can manipulate in the computer so we can see a lot more detail. The problem with MRIs, it's very, very expensive. So it's a great test, but oftentimes MRIs not the first choice because of its high expense. And then for joints, we can take a sample of synovial fluid. Synovial fluid is a sort of thick, slippery, yellowish, clear fluid that is found inside the joint capsule. And we can put a needle in just the right place and we can draw some of that fluid out and find out if we have an infection that we're dealing with or an autoimmune disorder that we're dealing with. Synovial fluid can be very valuable in terms of making a diagnosis about a joint. So first up is fractures, and I know you've heard about fractures before, so we'll not spend a ton of time on this, but a fracture is any break in a bone. So it doesn't have to be as extreme as this. Here we have a complete transection and a subluxation. In other words, the ends of the bone are not in their correct place anymore. This would have to be operated on or reduced somehow to get the two ends of the bone lined up in the right place. They can occur, most commonly it's trauma, so either a fall or a blow or something like that has dealt a lot of stress into the bone, into the skeletal structure, and one of the bones has given way. But we can also get fractures secondary to cancer that's either in the bone or somewhere else and eating away at the bone. We can get stress fractures in weakened bones. We see this in osteoporosis in like the vertebrae and the hips, where the bone basically gives way under the body's own weight. So we chart fractures just with that plus sign or the pound sign. So we classify fractures in a number of different ways. Complete versus incomplete. A complete fracture is where a single bone has become two bones. There are at least two pieces. Many fractures are not complete. Bones have some inherent flexibility. So oftentimes, particularly in children, one side of the bone will break, but it won't go all the way through. It's sort of like the twig of a tree. You can bend it and one side will pop open, but the other side stays intact. We call those green stick fractures. Open versus closed, or compound versus simple. An open or compound fracture is where the skin is broken as well. Now, technically, this is any break in the skin. It doesn't necessarily mean that the bone has punctured through the skin. But the classic open or compound fracture is from a massive trauma, so like a car accident, for example, and the bone has broken and literally been pushed up through the skin. So when you look at it, you see bone pieces sticking out, and you're looking down into the muscle cavity. So those are particularly nasty. A closed fracture is most fractures. This is where there's not a break in the skin. In a simple fracture, we have a single break, so it's a crack or a break through the bone, but the bones are in proper alignment and position. So like this is not a simple fracture, because here the two ends of the bone have moved relative to each other. So even though there's only one break and two bones, this is not a simple fracture. It would be a subluxed fracture in that case. Comminuted just means that the bone has been shattered, or at least partially shattered. So instead of two pieces, like you'd see in a simple fracture, in a comminuted fracture, you're going to have two large pieces and lots of small pieces. So here again, you see these in massive force traumas. So, car accidents, people falling off buildings, things like that, where the bone has not only broken but shattered into multiple pieces. And then a compression fracture is where the bone has essentially crushed. There's not really a line, a break in it. It's the bone has gotten smaller in one direction because it's crushed. We see these very commonly in vertebrae. In elderly people, they can have compression fractures just from osteoporosis, but you also see these like a person who falls from a building and lands on their feet. Their vertebrae can compress and crunch down, and these can typically be kind of difficult to treat. So some other types. An impacted fracture is where one end of the bone has been sort of jammed into the other in an abnormal position. Again, massive force trauma, car accidents. A pathologic fracture is a fracture that results from a weakness in the bone from some other reason. So let's say you have a lung cancer that is secreting parathyroid hormone. Well, you might end up with places in your bones that have gotten so weak that you go to walk downstairs or something like that and the bone breaks. So that would be a pathologic fracture, a fracture that really is the result of something else. A stress fracture is from repetitive use. So some joggers or runners that don't wear proper shoes end up with stress fractures in their tibia and fibula. That's one of the versions of shin splints. So they're not really, they're little partial fractures. So they're incomplete, but they can cause a significant amount of pain. And then a depressed fracture is something we talk about with the skull. And this is where a circle of bone has been, if we look down at the top of the skull, a depressed fracture happens when an entire intact circle has been all broken. And then what happens is when you feel this patient's head, part of their skull is lower than the other part, because essentially the skull has been pushed in. So, in most skull fractures, it's not complete. You'll have a fracture like that. But if you end up with a piece of bone that is separate from the rest of the skull, we would call that a depressed fracture. So, a hammer to the head or a major blow can cause that kind of thing. So, some other types. An oblique fracture is where the fracture line, instead of being straight across like you'd see in a transverse, it's sort of at an angle. Here's that comminuted, where we have two big pieces of bone, but then we have a lot of little bone fragments or bone shards. So it's a shatter effect. An open fracture, here the tibia, you might see this in a car accident from the brake pedal effect. The tibia has been sort of pushed out through the front of the leg. So you'd see, when you look at this, you'd see bone sticking out. That's an open fracture. Pathologic fracture from a bone tumor where you've got a little crack in the femur there. A segmented fracture is where you have more than one piece, not little fragments like comminuted, but where you have not just one break line, but you have multiple break lines. Usually these require surgery because they're not stable, so the surgeons will go in and put some screws and plates and stuff in there to keep these bones in line. A spiral fracture happens, if you imagine it like a chicken bone, and you twist it, one side one way, the other side the other way, the bone's going to kind of come apart in a spiral way. And we see that in, and that's what we call a spiral fracture. These are common in child abuse. And that's because in order to get that, you need to have a rotational force, which, you can get on a kid's arm. Green stick fractures we talked about already. Impacted, here's where the femur has broken and gotten lodged, sort of pinned in next to the pelvis by the muscles of the pelvis. We have two sort of special named fractures that are very, very common. So in a Colles fracture, this happens because of a fouche, a fall on an outstretched hand. Those of you who know Dr. Mock, she could have had one of these instead of the fracture she ended up with. But a classic Colles fracture is a both bone fracture. In other words, the ulna and radius are both broken. As the force came up through the hand, the edges of these two bones essentially broke off. In a Potts fracture, it's similar to a Colles fracture, only we see this in the knee, or at the ankle, rather. So again, landing from a great height on your feet, all that force can break off the fibula and break off the tibia, and you end up with this Potts fracture, or distal fibular-tibular fracture. And here's a compression fracture. Here's a normal vertebrae here, and you can see that this vertebrae has literally been crushed in on itself, so it's not a normal shape anymore. Sometimes these require surgery, sometimes they don't. It all depends on if the spinal cord or spinal nerves are being impinged or not. So lots of different types of fracture. So fractures, bones are very much alive. When we look at bones in the anatomy lab, they don't really reflect what they're like in real life. Bones are full of blood. They have a very rich blood supply. They have a very rich nervous supply. So when a fracture occurs, there is a significant inflammatory response. So the periosteum, or the membrane that covers the bone, gets swollen. There's a significant amount of bleeding that goes along with a fracture, and that's because bones are very, very vascular. So we get some of the pain is from stretching of that periosteum that surrounds it and from inflammation that we find there. There's a profound immune response as well. Chemical mediators are released that help to identify a fracture. Why does a broken bone hurt so much worse than just a bruise? Because there's all kinds of inflammatory chemicals that are released to sort of tell the brain that, hey, this is a major injury and not a minor one, and that area is going to need some care or treatment. So the bleeding eventually forms a clot, and then that clot is what starts the process of healing by forming the internal and external callus. All right. Let's see. So the pathway for healing, first you have a hematoma. A hematoma is just an area where bleeding has occurred into a confined space. So typically what we see in a fracture, if this is the bone here and our fracture is across here, the first thing that develops is a hematoma that looks a little bit like this, only it wraps all the way around. And that's because from the fracture there's been bleeding, and lining the surface of the bone is the periosteum, which is very, very strong and tough. So usually it stays intact, even if the bone's been broken. So you get this big hematoma. The phagocytic cells come in and remove anything that's broken or damaged. Fibroblasts start laying down new collagen, so they cover this area in collagen. The collagen then is replaced by chondroblasts, form a callus, a cartilage callus in this area. That cartilage is replaced by bone. So at some point in the healing process, the bone looks a little bit like that. It has a sort of bulge in it because what started out as a hematoma has now become bone. And then eventually the bone is remodeled so that it goes back to being just like it was before. Now, sometimes you'll still see a very thin, narrow line like on X-ray, but a bone that was broken a long, long time ago, you may not be able to identify on X-ray because even that disappears as the bone is turned over and remodeled all the time. All right. So hematoma, collagen formation, the formation of that callus or kind of collar around with cartilage, and then that cartilage is replaced by bone, and then eventually it gets all the way back to normal. Now, it is true that any place in a bone that has been broken, it actually ends up healing stronger than it was before because of an increase in calcium deposition in this area. So it's very uncommon once a bone is healed to break it in that same place. It's likely to break somewhere else instead. All right. So bones take a long time to heal. You know, anybody who's been in a cast will know that, you know, you're not talking about just a few days. You're talking about a few months before, you know, you're really back to normal use there. But there are a lot of factors that affect that speed of healing. So the amount of local damage, you know, if it's just a simple break, those heal much better than if this whole area has been disrupted, you know, like in a massive open, you know, compound fracture where you've got tibia, you know, sticking out through the skin. That's going to take longer to heal because of all the local damage that's occurred. You don't want to have any foreign material or infection. Open fractures are a big deal because bone is easily infected. And if you have a broken bone and open skin, you're set up for infection of that broken bone. So those patients are put on antibiotics to make sure that that healing fracture doesn't end up being a site of infection. The proximity of the bone ends. The most common reason for surgery after a fracture is to put the two ends of the broken bone in the right alignment. Because if you have a situation, you know, like this, you know, so you've got one part here and then the other part is, you know, sticking up here like that, that's never going to heal. You know, you have to get the two ends of the bone in the same orientation in order to have that healing happen. So the surgeons will go in, well, first they'll try to put it in place without surgery. You know, they'll pull on it and twist on it and tug on it to try to get those bones back in alignment. But if that fails, they'll go in surgically, put it back together, and then oftentimes they'll put hardware in. So they'll put like a screw here and a screw here and a metal bracket to hold those two bones in place. Most of the time the brackets stay. You know, like you just will have those in your arm forever. Sometimes in certain, like in joints, once the bone is healed, they'll go in and take them out. And then the usual healing factors. Blood supply, age, nutrition, other health, all the things that delay healing also delay bone healing. All right. So complications of a fracture, muscle spasms because the bones are not in the proper alignment and you've got all those inflammatory mediators around. So the bone or the muscles tend to tense up. It's also a defense mechanism. You know, if you've got bones that are suddenly unstable, if you tense up the muscles around that bone, you can still keep that limb intact. Like a person with a broken femur, let's say, might still be able to walk out of, you know, walk away from the car accident because it's not the bone that's holding them up, it's all the tense muscles around that bone. But it at least gets you into safety with your unstable femur. Infections, like we talked about, fat emboli, the marrow cavity of the large bones is full of adipose tissue, full of lipid. When you break that open, you can send little bits of lipid flying through the blood vessels. And they can lodge in the brain, they can lodge in the lungs, and they can cause infarction. So in a big bone break, you know, like a femur, a pelvis, a humerus, we worry about fat emboli, particularly if it's not a simple fracture, but a compound one where the marrow cavity is actually exposed to the vasculature. All right. Deformity, if the two ends of the bone are not lined up, you'll end up with a deformation in that bone, which can affect things like range of motion, strength, things like that. So, you know, the standard of care is you want to get those two ends of the bone as precisely lined up as you can. All right. For treatment, reduction is simply putting the bones back in their proper place. So a closed reduction is where they'll push, pull, twist, tug to try to get the two ends of the broken bone lined up. In an open reduction, that's the surgical version, which I described here. So they actually go in there, they put the bones where they're supposed to be, and they secure them somehow with plates or rods or screws or pins. All right. A potential complication of a fracture in the forearm or in the leg, the calf area, is compartment syndrome. Both of those areas are surrounded by very tough, dense fascia, layers of tissue that are full of tough collagen, and essentially this encasement prevents those regions from swelling very much. So if you have a tibial fracture, for example, there's lots of swelling that goes along with any bone break. Well, in the calf, there's no room for that swelling because of this fascia that surrounds the whole calf. So what you end up with is an area of increasing pressure. Now, at some point, the pressure from that swelling inside that fixed compartment can be so great that blood can no longer get to that area because when the pressure from the swelling exceeds blood pressure, ain't no blood going to move. So that is compartment syndrome, and it can lead to ischemia and infarction of that tissue and the foot too from compression of their arterial supply. So one of the reasons that surgery in those areas, forearm and calf, are not done right away, but oftentimes they're done several days later, is to allow the swelling to go down in an attempt to prevent this compartment syndrome. A cast that is too tight can also create this same effect because a cast doesn't give like our skin does. So again, we don't usually put a patient in a cast the day they broke their bone. We put them in a splint or a temporary cast, and then when the swelling has gone down, then we'll put them in the cast they're going to have for those 4 to 6 weeks. Did you have a question?
Just a quick question, because I've seen where they've had skin wore off.
Mm-hmm.
It was my niece, and they were saying, okay, we're going to put a cast on it. And I said, aren't you worried about infection? Oh, no. I guess they went ahead and covered it, and I'm thinking, she's got an open wound here, and they covered it with a cast.
I don't know. That seems a little strange, but
yeah.
I mean, you could still monitor for infection, I suppose, but that's not really compartment syndrome.
No.
But it's what do you do with an open wound and a cast?
Yeah.
I mean, the more important thing is the cast, and that may have been what they were thinking, because you have to immobilize bones, particularly in the forearm where they can move a lot, if you're going to get any kind of healing. So they may have just risked the infection to immobilize the bones. Yeah.
Well, don't they usually cut a window in the cast?
They can. I mean, they don't usually do that, but they can cut a window in there to see what the skin is doing underneath there, you mean? Yeah. And it depends. Like, there again, we all think of a cast as kind of a big deal, but they put casts on every day. So it's easy for them to cut it off, put another one on. So bring it back in 2 weeks, look at this, cut it off, look at the skin, put you back in another cast. Yeah. A dislocation is where bones have not broken, but they've come out of articulation. So, we have many joints in our body, and all of them occur where two bones come together and are held in place by, tendons and ligaments and muscles. But a dislocation can occur, and this is where the joint has been disrupted. One bone has been pulled out of place, essentially. The most common dislocation is the shoulder, and that's because the shoulder is intrinsically weak. We have a very flexible shoulder compared to other animals in the animal kingdom. Not many animals could reach around and scratch their own back, but we can do that. But it means that our shoulder is relatively unstable. This is the most common kind of shoulder dislocation, and that's an anterior-inferior dislocation. So this part of the bone right here should be sitting in this little cup right here. But a blow to the high back, like here, can knock a shoulder out. Once you've had a dislocation, you're more likely to have another one. So some people have even learned how to replace their own shoulders. And you've seen this maneuver in movies, I'm sure, where you go up against the door frame and you slam your shoulder in. That is a anterior inferior shoulder dislocation reduction, done Hollywood style. All right. In the emergency room, of course, you don't do that. You sort of pull on the arm and you push at the same time, and it'll pop back into place if it's not too swollen. All right. Sprains and strains, these are specific words, and people have a tendency to really butcher this short little vocabulary. So a sprain is a tear in a ligament. A strain is a tear in a tendon. So think muscle strain, not sprain. A sprain, remember, ligaments attach bone to bone. Tendons attach muscle to bone. So a muscle strain is a tear in a tendon, and a sprained ankle is a tear in a ligament. Now, it doesn't have to be a complete tear. It can be just a partial tear, because a complete tear is what we call an avulsion. So this is where a ligament or a tendon has been completely pulled off the bone. This doesn't happen very often because ligaments are almost as strong as the bones they connect, and where the ligament connects to the bone, there are little tiny fibers that actually go down into the bone concrete itself, the calcium part of the bone, and are attached very, very tightly. So avulsions, again, are high force events. This is, a big football hit or a car accident, things like that. We immobilize these to try to promote healing by keeping that area relatively immobile so that swelling can go down and healing can occur. All right, so our first question is about fractures. A 65-year-old Hispanic female is admitted to the hospital with a pathologic, compound, transverse fracture of the femur. Yes, you can line all those words up together. Which of the following statements best describes this type of fracture? All right, jump in there if you're playing. All right, so the correct answer here is B. The key word here is transverse. A transverse fracture goes right across the bone. Now, if you put C, I would kind of call that correct too, because technically a transverse fracture is perpendicular to the bone. If you had, if here's your bone and here's your fracture, well, that is a 90-degree angle, so either B or C. So those other words, remember, pathologic means that there was some underlying reason for the fracture, so osteoporosis or a lytic lesion from cancer or something like that. And compound means that the fracture was poking through the skin, or that there was a break in the skin that was part of the fracture. All right, another one. 12-year-old female hurts her ankle while playing basketball. Tests reveal that she tore a ligament. So what would we call that condition? Oh, sorry. All right, that's everybody's playing anyway. So that's A, a sprain. So a sprain is a torn ligament, a strain is a torn tendon. So try to use them accurately, and then maybe other people will too. All right, so past the fractures and into actual bone diseases, not traumatic events. Probably the most common clinical bone disorder in the country is osteoporosis. Now, what does that mean? It's a decrease in bone mass and density, and those two things are not necessarily the same. So bone mass is how much bone weighs. Bone density is how hard it is. So how much calcium is there in that mass? What you want to see is you want to see a high density, relatively low bone mass, because we want our bones to be efficient. So in the young person, you have a lot of bone density. So a small amount of bone can withstand a lot of force. So excuse me. Osteoporosis is a breakdown in that. So there's two forms. The one we're all familiar with is primary osteoporosis. And this is the weakening of the bones with age. So typically it's age 50 plus years. It's associated with the decrease in sex hormones, particularly in the female. When the menopause occurs, progesterone and estrogen drop, and progesterone and estrogen help to keep bones strong. So osteoporosis accelerates after menopause. It's also associated with a poor calcium intake. People who don't get enough calcium in their diets don't have the calcium to make strong bones. So you end up with osteoporosis there too. So ultimately it's idiopathic. In other words, we don't know exactly what causes osteoporosis, but we have a pretty good handle on it now. We know that hormone replacement therapy together with calcium supplementation can greatly improve osteoporosis over the long term. Now, secondary osteoporosis is the one we don't hear about very often, and this is osteoporosis that is a complication of something else. So we see this in parathyroid hormone disorders. People who have an elevated parathyroid hormone develop osteoporosis. Patients who have end-stage renal failure, they also develop osteoporosis as well as osteomalacia. And there again, it's because the kidney plays a major role in controlling calcium levels. So essentially, the pathophysiology of osteoporosis comes down to one fact, and that's this first one. Bone reabsorption exceeds bone formation. So if you think back to A&P, we talked about how bone was alive, and it's constantly being made and broken down. So every day, part of the bone is dissolved and part of the bone is remade. So we call that remodeling. And the reason our body does that is to keep our skeleton fit for whatever our activity level is. If you start training for a marathon, your bones are going to get stronger as well as a little bit lighter, because that's what's needed. If you decide to spend a year, in couch potato mode, your bones are going to get weaker and somewhat heavier, at least at first. So in osteoporosis, it's a breakdown of that balance. More bone is being reabsorbed than is being laid down. So what happens over time is bone gets weaker and weaker. So essentially it has less calcium, less hardness, and it makes it more susceptible to fracture, particularly in compact bone. Remember, we have compact bone and spongy bone. Osteoporosis preferentially affects compact bone. We can't diagnose this with simple x-rays. You're not going to see osteoporosis until it has gotten extremely bad on normal x-rays. So instead, we do the complex DEXA scan or bone density scan, which tells us how much calcium there is in every volume or every ml of bone. Some common things we see: compression fractures, vertebrae, wrist, and hip are the common ones. Some little old ladies who break their hip, they didn't fall and break their hip broke and they fell because they had osteoporosis and they took a step off the curb and the head of the femur just broke and then they collapsed to the ground. Now, what do they think happened? They think they broke their hip when they fell, but in reality, it's a compression fracture or a pathologic fracture that led to that. These compression fractures of the vertebrae can change spinal alignment, so you can get kyphosis and scoliosis. So, some of the little hunched over little old people are hunched over like that because they've had numerous compression fractures. So basically, instead of their spinal cord sitting like this, it sits in a much more curved way. Because as our picture showed earlier, one of the common ways that compression fractures occur is in a kind of wedge like that. So if we go from this shape to this shape, well, we're going to increase the curvature of the spine from straight to a curve instead. All right. Osteoporosis risk factors: age greater than 50 years, a sedentary lifestyle. Bone is really cool because the more you stress it, the stronger it gets. Okay, that's cool. That means that, if you were to, start a very intense exercise regimen, your bones would literally get stronger as you work them out. However, the opposite is also true. If you don't stress bones regularly, they get weaker and weaker. Again, the body doesn't want to carry around a bunch of heavy bone if it's not being used. So decreased mobility, so somebody who's in a wheelchair, for example, or somebody who's sedentary, increased risk of osteoporosis because the bones aren't being stressed like they need to be to maintain calcification. Hormonal factors, we talked about estrogen. Testosterone does the same thing in men. So men who have a low testosterone level are also going to be at increased risk of osteoporosis, just like the postmenopausal woman. Steroids and parathyroid hormone trigger osteoporosis. Cigarette smoking, a low BMI. This is one of the few things where being heavy actually helps, because if you're heavy, your bones are stressed more than if you're not. So people who are very thin and frail, they don't have enough mass to stress their bones very much, so that too can lead to osteoporosis. Asian and European ancestry, other groups don't get osteoporosis at the same high level. And then a relatively new one is caffeine. Lots of caffeine in life is also a risk factor for osteoporosis. So if you're a caffeine junkie, take your calcium pills. Treatments, dietary supplements with calcium. Very often, this is we also include citric acid along with this, and that's because calcium by itself isn't absorbed particularly well, but in association with citric acid, like you find in orange juice, calcium absorption is greatly increased. So if you're taking a calcium supplement, it's a good idea to take it with something acidic, like orange juice. It's one of the reasons they started adding calcium to orange juice in a lot of brands. Weight-bearing, physiotherapy, bisphosphonates, we don't really use those very much anymore. Calcitonin can be given to improve the laydown of calcium in the bones. Parathyroid hormone. And there's a bunch of new therapies for osteoporosis, which your book doesn't go into. Some of them are advertised on TV. There's a once-a-month injection. There's a once every 2 weeks injection. And all of those work on this calcitonin parathyroid hormone system that helps to lay down bones. So that's the most common one, osteoporosis. Other ones, rickets and osteomalacia. So rickets is a vitamin D deficiency. Without vitamin D, we don't absorb calcium very well. So if we don't absorb calcium, even if there's plenty of calcium in our diet, the patient will still be calcium deficient. It's like they're not getting enough calcium in their diet when vitamin D is absent. Now, in this country, milk is fortified with vitamin D, so we don't see much rickets anymore. But we used to see rickets, particularly in people that have darker skin tones, because the darker your skin, the more UV radiation you need to create vitamin D for yourself. One of the few good things that sun exposure does for us is exposure to UV creates vitamin D. So even if you're not getting it in your diet, you can make it, but only if you have vitamin D, or only if you have UV exposure. There are a couple of other causes, phenobarbital, which is an anti-seizure medication, offsets vitamin D that can lead to that. But the interesting part about rickets is the bones look normal, but they're flexible. Instead of being hard like bone is supposed to be, they're sort of rubbery, like a dense rubber. So the classic, I don't think I have a picture, no. The classic presentation of rickets is bowed legs. So the patient's legs literally bow out. And the reason for that is, you've got all this body weight that's pushing down, And as it goes through the bones of the legs, if your bones aren't rigid, the bones, they end up getting pushed out into this bow shape. So the classic picture of rickets is the bow-legged kid with dark skin. All right. Just like everything else in the body, bones can have tumors in them. Bones are a connective tissue. So the tumors that grow in bones are sarcomas. Remember, sarcoma is the magic word for a connective tissue tumor. The most common primary neoplasm of bone is the osteosarcoma. Usually it occurs in the long bones of the leg. So this is an honest-to-goodness bone tumor, where bone tissue is overgrowing and growing outside of the body's control. This is a cancer that occurs in the young, not necessarily the old. So children, adolescents, young adults. It can be particularly nasty because it may result in an amputation. If it's progressed to the point where it can't be treated with chemotherapy or resection, one of the treatment options is amputation, and you don't want to see amputation in young people. You don't want to see it in anybody, but particularly not in young people. So the warning sign here is bone pain at rest. You know, if you're an active adolescent, you're an active young adult, active child, every once in a while you're going to have some bone pain, you know, because you landed wrong when you were jumping or you tripped and fell, those kinds of things. But that pain should go away when you have that, you know, bone rested and elevated. If the pain doesn't go away with rest, then that's a sign that there's something else going on, and it might be an osteosarcoma. So here's what that looks like. This is normal, healthy, living bone up here. And you can see this big area right here. This is that osteosarcoma. So it's literally growing out of the side of what looks like the tibia here. So this is the lateral side of the tibia. So osteosarcoma. The bone tumors metastasize, oftentimes to the lungs, which is the most common site of metastases of all tumors anyway. And then the treatment, you try to excise the tumor, surgical amputation if you can't excise it, and then chemotherapy to try to kill the metastases. You know, you can imagine that having bone growing in your lung is probably not good for your respiratory system. So one of the weird things about this osteosarcoma is it is bone growing, but you can end up with bone growing anywhere, you know, under the skin, in the brain, because of metastasis. All right, so osteoporosis, osteosarcoma, rickets. Now let's look a little bit at joints. These are very common disorders. This one, very exceedingly common, particularly in our population that's getting older all the time. So osteoarthritis, there's two kinds of arthritis that affect people, and it's important to be able to distinguish between the two. That gets asked on board exams. It gets asked on in other places. You have to be able to discriminate osteo from rheumatoid. So the two forms of arthritis that affect adults are osteoarthritis and rheumatoid arthritis. And they're very different. Their patterns are very different. The only thing that's really in common about them is they both affect joints. And they're both progressive degenerative joint diseases. But other than that, their other patterns are different, you know, and they both cause joint pain. But we'll start with osteo. Osteoarthritis is the wear and tear arthritis. You know, so let's say, you know, you are a carpenter. Well, you might end up with osteoarthritis in your hammering arm because anything that you do regularly and a lot can lead to osteoarthritis. You know, just like everything else, our bones and cartilages wear out, you know, and if you use a thing a lot, it's going to wear out faster. So osteoarthritis is that wear and tear arthritis. The incidence is increasing, probably because our population is getting older. There is a genetic component. You know, if your mom and grandmother had osteoarthritis, you probably will too. And it probably has to do with how durable your joint surfaces are. So the pathophys here is the articular cartilage is damaged. So remember that bone, you know, ends in like this, and then between this bone and the next bone in the chain, so this is the tibia, this is the femur, the ends of bones are always covered with this strong, slick, smooth cartilage called articular cartilage. Bone should never touch bone. In a normal, healthy joint, it's cartilage that touches cartilage at that joint, and that's what it evolved to do. When this articular cartilage is damaged and bone starts to grind on bone, that's osteoarthritis, a damage or a deficit or defect in the articular cartilage. And once you get even a little defect, then it starts to get worse, because now it's like sandpaper. So when it started, this side was smooth and this side was smooth. But if you develop a little rough spot right here, as this joint gets moved throughout the day, now this rough spot starts rubbing away at the other cartilage, and so on and so on. So essentially, this the damage to articular cartilage creates more damage to more articular cartilage in that same joint, and then at some point, the bone underneath that cartilage gets exposed. Now you're having massive pain, and you're on your way to that joint not moving anymore, because the joint, if bone starts to rub against bone, what ends up happening is these bones start to kind of fuse together. So that's always what we're trying to prevent in osteoarthritis, is a reduction in range of motion or in ability at that joint. All right. So some components of that: osteophytes are little bits of bone that are found in the joint capsule that have been rubbed off. So as bone starts to rub against bone, little pieces of bone sort of are rubbed off, and they end up floating around in that articular cartilage. And there again, they act like sandpaper. If you have two panes of glass and there's water in between them, they run against each other very smoothly. If you sprinkle some sand in there, though, you're going to start scratching the glass. And that's essentially what happens with these osteophytes, is it continues that process of eroding those articular cartilages until they're just not there anymore. So your range of motion is affected. You get pain and inflammation in the affected joints. It gets worse with weight bearing. One of the classic osteoarthritis points is, in the morning it's better than it is at night. And the reason for that is, in the morning, that joint's been at rest, right? You've been sleeping, not moving, not hammering, not walking, whatever. But by the end of the day, you've been using that joint all day, and the more you use it, the worse it hurts. So osteoarthritis starts good in the morning and gets worse over the course of the day. Rheumatoid arthritis is the opposite pattern. In rheumatoid arthritis, the joints are painful and stiff in the morning, and they get better as you move those joints, because you sort of loosen up those inflamed membranes. So here's osteoarthritis in a picture. Here's the joint capsule. This used to be articular cartilage here, but you can see that it's been eroded away. Little chips of bone and cartilage are present. Those are the little osteophytes floating. On the sides of the bone, you end up with new bone growth as the bone tries to resolve this problem. And you get these little bone spurs, which are also called osteophytes. They can actually grow together and lock a joint. If this connects with this joint doesn't move anymore. Again, it's not the greatest way for the body to solve the problem, but at least it eliminates the cartilage problem. But it means you lose mobility in that joint. In the old days, in the 1800s, people would, essentially a knee would lock up, and they wouldn't be able to move that knee anymore because of osteoarthritis, and essentially the femur and tibia sort of grew together. All right. So the primary form of osteoarthritis, it usually is in weight-bearing joints, so large joints. These are knees and hips, although it can affect any joint, but ankles, knees, and hips are the big one, particularly when you add obesity to it and aging. The secondary osteoarthritis, this is the repetitive use. So, these are the elbows, shoulders, and wrists of people who use those joints on a regular basis, usually as part of their occupation or part of a hobby. So like your major league pitchers are kind of a setup for shoulder and elbow osteoarthritis from all that repetitive high force action. Okay. So weight-bearing joints most frequently affected, but fingers can be involved as well. So typically osteoarthritis is large joints, rheumatoid arthritis is small joints, but fingers are the exception. Because we use fingers all the time, both forms can affect the finger joints. So signs and symptoms, pain with weight bearing and movement, a reduction in range of motion at the affected joint. Walking becomes difficult. These people are predisposed to falls because their joints lack mobility, so they tend to be a little unbalanced. All right. Treatment. You try to reduce the stress on the affected joint as much as possible. So like if you've got a knee that's going out or a hip that's going out, you might be on a cane to sort of help offload some of that weight on your osteoarthritic joints. Pace activities. You want to stay mobile and active because that, the last thing you want is to not use that joint because it'll freeze up even faster. But you have to pace yourself to not cause further damage. So mild exercise as well as range of motion activities. All right. Osteoarthritis, obviously lots of treatment options. Most people start with NSAIDs because they control not only the inflammation but the pain as well. And the new generation of NSAIDs like Celebrex, COX-2 inhibitors are often prescribed for osteoarthritis because they actually help with the problem, which is the inflammation. Other things have been tried, glucosamine, chondroitin supplements. You see these advertised on TV. And there is some evidence that they do help to reduce the speed at which osteoarthritis progresses. Okay. In the end, the final treatment is surgical joint replacement. You will take care of patients who've had joints replaced. We can do elbows, we can do shoulders, we can do knees, we can do hips, we can even do ankles. So you will take care of patients that have metal knees. Obviously you can't see that, but the replacement joint is usually made of titanium and provides as much of the normal range of motion as possible. The biggest downside to joint replacement is it takes a long, long time to recover from it. Replacing a hip joint or a knee joint is major surgery. A lot of muscles were going to have to be moved aside or cut. So the road to recovery for a joint replacement is very long. But once you have it done, your osteoarthritis is gone forever in that joint because the titanium joint is not going to be affected by the immune system and the wear and tear. All right. So the other one is the rheumatoid arthritis. It's a little more complex because unlike a wear and tear type scenario, rheumatoid arthritis is an autoimmune disorder. So this is where the body's own immune system is attacking the articular cartilages and the joint capsule. So we see this more commonly in women than men, and we can see it across age groups. So osteoarthritis is usually a problem with people 50 plus. Rheumatoid arthritis can start even in the teens or even younger. Now, normally, rheumatoid arthritis doesn't get real bad until you're 40, 45 plus. But young people can have rheumatoid arthritis as well. So the principal pathophys here is inflammation. So the immune system attacks the synovial membrane, which causes inflammation, cell proliferation. That serves to deform the joint. So extra tissue is laid down, and the joints start to get sort of swollen and big, but still hard. The cartilage erodes just like it does in osteoarthritis. And you can get ankylosis. Ankylosis is joint fixation. This is where a joint that used to move doesn't move anymore because either the bone has grown together or the joint capsule is so rigid and inflamed that that joint can't move anymore. All right. So fibrosis, synovitis, or inflammation of the synovial fluid. I don't think we have a picture of pannus formation, so we're going to skip that part. All right. Around the infected joints, you often get atrophy of the muscles. If it hurts to move a joint, you tend to move it less, and if you move it less, the muscles get smaller. So you get atrophy. The bone alignment can shift as the synovial membrane swells and is deformed. It will literally pull the bones out of shape. So, you'll see sometimes, little old ladies with really gnarly hands. Their hands don't look like they're in alignment anymore. That's usually rheumatoid arthritis. It deforms joints. Osteoarthritis can do that, but usually deformation is rheumatoid arthritis. Autoimmune destruction of that joint cavity that has pulled the bones out of alignment. All right. So here's some of those changes. We have inflammation of the synovial membrane here. The pannus is basically this kind of lining of inflammation that sort of covers the whole inside of the joint capsule. It can lead to ankylosis, where the bones are actually fused. You can see this doesn't belong here, but because it's present, these two bones can no longer move next to each other. All right. And here's some of that deformity. So she's got, here's her ulna. So her joints are drifting towards the ulnar side. You can see the big knuckles of classic rheumatoid arthritis. When you palpate these, they feel hard like bone, and that's because, the ends of the bone have been deformed. So we get this sort of appearance. You see the little knob at the top. So this is a classic hand of a rheumatoid arthritis patient. All right. Osteoarthritis only affects the joint. It's not a systemic disorder. It's a wear and tear effect at a particular joint or joints. Rheumatoid arthritis is a systemic disorder because it's an autoimmune disorder. So you don't just get joint effects, you get other effects too. Classic inflammation, autoimmune stuff. So marked fatigue, depression, malaise, anorexia, low-grade fever, iron deficiency anemia, resistant to iron therapy. These are all things you see in a person with an autoimmune disease in general. And because rheumatoid arthritis is an autoimmune disease, you see all of these things in RA too. We don't know exactly what causes it. We know it runs in families. There's a substance that's found in the blood called rheumatoid factor. And in patients with rheumatoid arthritis, their rheumatoid factor is high. And if you are a person with a high rheumatoid factor, you're at increased risk for rheumatoid arthritis, as well as autoimmune diseases in general. So there's a genetic factor, but it's not simply a genetic disorder. So it's more of a predisposition. Signs and symptoms: painful affected joints that are stiff. Stiff joints in the morning, that's rheumatoid arthritis. Joints that get stiff over the course of the day, that's osteoarthritis. And it's because of the two different mechanisms. Osteoarthritis is wear and tear, so the more you use it, the more it hurts. Rheumatoid arthritis is autoimmune. So while you're sleeping, your immune system is attacking your joints. When you get up in the morning and you kind of stretch your hands and you stretch your other joints, they loosen up as those membranes are stretched a little bit. So it's rheumatoid arthritis is worse in the morning, and then it gets better as you start moving around. Redness and swelling, again, you don't usually get that with osteoarthritis. You get it with rheumatoid. So red, swollen knuckles, rheumatoid arthritis. Knuckles that just hurt, osteoarthritis. All right. RA is usually the small joints, so like the fingers, wrists, toes, you can get it in your toes. And eventually the joint, its movement becomes impaired, and finally it gets fixed and deformed. So there again, the next time you're taking care of a little old lady with deformed hands, ask her to make a fist, and you'll see that some of the fingers don't flex anymore. and that's when the joint becomes fixed. It can't move, so it's stuck. It's locked in that position. We talked about that already. So treatment, it's tricky. All autoimmune disorders are tricky to treat. And rheumatoid arthritis is one of the reasons why there are rheumatologists or autoimmune specialists. Because, you're walking this balance between, you want to turn the immune system down, but you also need an immune system to fight off infection. So it's this sort of balancing act. So rest and moderate activity, both are good for rheumatoid arthritis in the right balance. Hot and cold, PT and OT help to increase the length of time that it takes for a joint to be locked. So the more you move it and stretch it, the longer it's going to last you. NSAIDs again, glucocorticoids, but only if it's severe because they have such bad side effects. And now there's a bunch of new medications for rheumatoid arthritis, again, that your book doesn't go into, like infliximab and rituximab. Again, some of these you'll hear about on the TV. These are true disease modifiers. They're actually immune suppressors that affect the branch of the immune system that rheumatoid arthritis is based in, which is the cell-mediated branch of the immune system. So some of these medications may stop. We don't know yet because they haven't been around yet, but they may stop the progression of rheumatoid arthritis. And what everybody would like to have is a medicine that can actually reverse some of those deformities, but that's a long way off still. All right. There is a version of rheumatoid arthritis that affects children. We call it JRA, or juvenile rheumatoid arthritis. Unlike the adult version, juvenile JRA is usually large joints. Typically, it's knees and hips, knees most commonly. The onset is much more acute. This is a kid who in just a few months will go from normal to, swollen red knees that are hard for him to move. So it comes on much, much faster. There are multiple different types. Still disease is the systemic form of JRA, and this is where you get sort of a widespread inflammatory response. So fever, rash, hepatomegaly, and joints that are involved. But this is sort of a version of JRA. Another version causes joint inflammation in multiple joints at once. And then in the third form, you have 4 or fewer joints, but also there's an eye involvement. So we're not going to get into a lot of JRA, obviously. But just know that rheumatoid arthritis has a juvenile version, and it's more complex. There's multiple different types, but the take-home message is the big difference is in kids, it's the large joints that are affected by rheumatoid arthritis, and in adults, it's the small joints, particularly at the fingers. Joints can get infected, and that is also an arthritis. Remember, arthritis just means inflammation of the arthros, which is the joints. This is called a septic arthritis. The classic board picture here is it's a single red, swollen, painful joint with decreased movements. Normally, osteoarthritis and rheumatoid arthritis, it's not just one joint that's affected, and it doesn't come on real fast. If you have a sudden presentation of a single red swollen joint, you have to assume that it's an infectious arthritis. So it's one of the times where we will sample synovial fluid, is we need to, because an infectious arthritis or a septic joint can cause joint deformity and loss of motion in that joint. So it's kind of a relative emergency. You want to treat that infection vigorously and rapidly to try to avoid any cartilage damage, which could then lead to osteoarthritis. So we tap the joint, we get some synovial fluid out, we send it for culture. And then joint infections are notoriously hard to treat with antibiotics. So frequently, these patients will be on 4 to 6 weeks of IV antibiotics. So they often will have home health care nurses that come and give them daily injections so that they don't have to stay in the hospital that whole time. All right. Another common joint disorder, which is troublesome but doesn't cause like massive deformity like rheumatoid arthritis does, is gout. So it's also called gouty arthritis. And it's a uric acid problem. Some people don't metabolize uric acid very well. Uric acid results from the breakdown of the nucleotides. So the RNA and DNA nucleotides, in their breakdown, their uric acid is formed. Now, most people excrete uric acid very well through their kidneys. But some people, their uric acid level is always high. The problem with uric acid is it precipitates. Just like you saw in chemistry, you can mix things together and like a powder will form and fall to the bottom of the beaker. Gout is just that. Crystals of uric acid form in the synovial joint. Now, the problem with that is these are not little round, soft crystals. These are like little shards of glass. So they're pointy and they're very sharp. And you can imagine that if you have these little crystals floating around your synovial cavities, it's going to hurt. So the single most common joint affected is the hallucis, or the big toe joints, where the uric acid gets into that synovial, makes crystals in the synovial membrane, and it causes a great amount of pain, not just from motion, but also from the impact of this uric acid on the synovial membranes. All right. So why do people have this elevated uric acid? It can be from inadequate renal excretion. Some people just don't get rid of it very well. Chemotherapy can trigger gout even in somebody who's never had gout before. The reason is chemotherapy targets rapidly dividing cells. Rapidly dividing cells use a lot of nucleotides. So when you destroy those cells, your uric acid level goes up, and you can end up with a gouty arthritis picture, even in a patient who's never had gouts before. Other metabolic abnormalities, and for some people it's genetic. So the inflammation in the joint causes redness, swelling, and pain, like you'd expect inflammation to cause in a joint. The treatment is to reduce uric acid levels. So you can do it through diet, or you can do it through some medications. But if you keep the uric acid level low, no crystals form. No crystals means no pain, and no pain means no gout. So the diagnosis here is to look at synovial fluid and to look at uric acid levels in the blood. But you have to be careful because NSAIDs can actually affect the appearance of uric acid in the blood. So it's a rare time where we have to tell patients not to take their medicine before a blood test. Okay. And then our last one is a long, complex word, ankylosing spondylitis. This is a progressive degeneration of basically the lower part of the spinal column. So you remember we have cervical vertebrae, thoracic vertebrae, lumbar vertebrae, and sacral vertebrae, right? Well, ankylosing spondylitis is where the sacroiliac joint and the intervertebral spaces basically lose their flexibility. They get locked together. It's common in men aged 20 to 40, so this affects fairly young people. It's deforming, and it can dramatically limit patients' range of motion. We think it's an autoimmune disorder that has a genetic foundation, but we're not sure. But it's a progressive condition. It usually starts at the sacroiliac joint. That's where the sacrum connects to the iliac crests on the side. So if this is your sacrum, and then off to the side is your pelvis, this is the sacroiliac joint, where the sacrum joins up with the iliac crest to form the back part of your bony pelvis. The vertebral joints get inflamed. Eventually they fuse, so you lose mobility. You get lots of inflammation in the lower back, and then it starts to move up the spine. Eventually, when it proceeds high up into the thorax, your lung expansion is limited because the ribs can't move up and out like they're supposed to when you take a breath in. So the classic signs here are lower back pain in the morning and stiffness in the morning. There again, if it's your typical lower back pain, In the morning, it feels pretty good. It's by the end of the day that your back hurts from whatever work you've been doing. In AS, that pain is there in the morning because there again, it's an autoimmune disease. So when you haven't moved that joint in a while, like overnight, it has a tendency to get stiff and painful. You also see fatigue, fever, weight loss because it is a systemic autoimmune disease. And then treatment. There's no specific treatment for ankylosing spondylitis, but we do treat the pain. Patients that stay in good shape keep their mobility longer. So this is, we want to encourage people to have a daily exercise plan. And then as the condition worsens, we send them to PT and OT to try to maintain their range of motion and their mobility. So here's what we end up with, an ankylosing spondylitis. We get this kind of shape as the vertebral joints become stiffer and stiffer and eventually fuse together. We get a kyphosis here, and here's that sacroiliac joint right here, which is where it usually starts. And it usually starts with low back pain that's off to the sides. All right. So a few more questions, and then we'll call it a day. A 70-year-old female presents with a hip fracture. She's diagnosed with osteoporosis. One factor that likely contributed is which of those? Oh, okay. So now I'm down to 8, I think it is. What? Oh. Have you been doing that all night?
Yeah, you didn't see me.
No.
Do you want me to rank this one?
No. There's only 2 anyway. All right, jump in there, everybody. I guess that's the one we're down. Okay. So the correct answer there is B, decreased estrogen levels. 70-year-old, definitely postmenopausal. Now, in the modern day, you'd be surprised at how many women are on hormone replacement therapy. So the picture of osteoporosis is going to be different by the time we all get to that age than it is right now. But hormone replacement therapy has really only been widely used in the last 10 to 15 years. So still, most of our little old ladies that are around us didn't have hormone replacement therapy. So the decrease in estrogen after menopause is going to contribute to their osteoporosis. All right, a 46-year-old male presents with severe pain, redness, and tenderness in the right big toe. He was diagnosed with gouty arthritis, not surprisingly. The symptoms he experienced are caused by the crystallization of what within the synovial fluid? That one must have been easy. I got all the correct answers. Very good. C, uric acid. And there's a commercial out about this. The guy who carries around the beaker full of green stuff. Have you all seen that one? Oh, it's a gout medicine that it says anyway that it reduces uric acid levels. So, all right, that's it for tonight, folks. I will.